So I'm going to talk about the non-surgical management of hip and knee arthritis. And you say, why is he talking about non-surgical treatment? Well, that's kind of the pathway that people go through before they need surgery. And the idea behind that is to make people as comfortable as possible and hopefully, in some cases, delay the surgery as much as reasonably possible until they are ready to go. So just a little bit about me. I'm the chief of orthopedic division at the Beth Israel. I'm a Boston College grad. Anyone from BC here? Oh, good, no one. All right, good. I went to Tufts Medical School, and I did a residency at New England Medical Center and a sports fellowship at the Children's Hospital in New England Baptist. I'm one of the team physicians for the U.S. figure skating team, and actually was lucky enough to be one of the team physicians at the 2010 Winter Olympics. So what I want to do is talk about arthritis facts, diagnosing arthritis, kind of show you what it is, x-rays of what it would look like, some of the non-surgical treatments, and then just touch on some of the newer techniques we're using, some of the regenerative techniques that's out there. I know I get a lot of questions about that. I'm sure some of the people here do as well. So with apologies to David Letterman, we usually see joint and extremity injuries quite a bit, obviously, and this is sort of the top 10 things of what people present with. Knee, shoulder, hip. I do mainly knee and hip, so I'm definitely in the top 3 of that. Dr. Stanwood over here can vouch for the shoulder side of things. And also, again, with further apologies to David Letterman, the types of injuries are things that lead people to show up in our office. One of the main things is the acute trauma, and we do have an urgent care center for that. Sprains, strains. Arthritis is about the number 4 down the list. And beyond that, tendonitis, bursitis, gout, which we also see there. So arthritis is really the focus. So what is arthritis? Well, it's really acute or chronic inflammation of a joint. Arthro meaning joint, itis meaning inflammation. So that's where the root of that word comes from. So as far as facts, approximately 350 million people worldwide have arthritis. It affects about 40 million in America, about 1 out of every 4 people. The number of people is increasing due to the advancing age of the population. And most people over the age of 60, me included, have some degree of arthritis. About 60% of people with arthritis are women, so it is definitely not an equal opportunity employer there. And it does cause certainly various degrees of disability. And as far as age, this gives you an idea of what the age spectrum is. Obviously, the older you get, the more likely you are to have arthritis. And it's projected that as the population ages further, the number of arthritis victims, if you will, is going to increase probably about another 1/3 over the next decade or so. $60 billion per year in cost for arthritis. The disease is physical, but it also enacts quite a mental toll and emotional toll as well. So the types of arthritis, most of what we see here, you see that big piece of pie, it's about a little over 2/3 is osteoarthritis. That's the wear and tear. That's your tires going bald on the car kind of arthritis. In addition to that, the next most common is some type of an inflammatory type of arthritis. That would include rheumatoid arthritis and types of inflammatory arthritis such as ankylosing spondylitis, juvenile rheumatoid arthritis, and in there is also gout, pseudo-gout, anything that can cause inflammation of a joint. But osteoarthritis is by far the most common. As far as risk factors, age, activities, we all know people who play sports had injuries and they go on to develop arthritis of either a hip or a knee or other joint. Weight, the more stress you have on your joints, the more likely you are to wear those out. Genetics, some people are more prone to arthritis than others. Your cartilage makeup is a function of your genetics. And we all know people or families that have had, a brother that had a knee replacement, a father, a mother. They tend to have multiple people sometimes in their family with that type of affliction. Congenital factors. Hip dysplasia is the one that comes to mind most frequently. This is something where the hip does not form properly. It forms as a very shallow socket, and that can cause problems by increasing the forces, kind of pounds per square inch, if you will, that causes the hip to wear out at a faster rate. Trauma, fractures, especially around joints or into joints, that's a very high contributor to arthritis. And actually, once you've had a fracture into a joint surface, by definition, you already have some degree of what we call post-traumatic arthritis. Illnesses, and it's not just illnesses affecting the joint itself. Certainly, if you have an infection in a joint, that can cause destruction of the articular cartilage, but also other illnesses. People who require, say, high doses of steroids for bad asthma or something like that are more prone to get conditions such as avascular necrosis, where it can affect the circulation to the joint and the bones around the joint. That can lead to deterioration. And we talked about, just briefly touched on infection. That causes damage to the joint by literally dissolving some of the cartilage surface over time. So the goals of treatment, it's really first and foremost to control pain, because pain seems to be the main thing that people complain about. We also want to try to preserve function of the joint, and we also want to slow the progression of the disease. So this is an example of a normal knee joint. The white you see on the bone, the upper bones of the femur, lower bones of the tibia, and that little thing way on top there is the patella that's sort of reflected back. That cartilage surface is sort of a rubbery surface. It's very smooth. It's made of chiefly about a little over 50% water. As pressure is applied to it, a little bit of that water actually kind of leaks out and acts as a lubricant. There's also a lubricating fluid called synovial fluid in the joint, and that allows those two surfaces to move very smoothly together. This is an example of a hip joint. The hip joint is a ball in a socket, and it kind of that ball is kind of gray. Sorry about that. It's got sort of a gray surface on it, but it's actually, that's the articular cartilage, and that's a very smooth surface as well. That fits inside the socket. It's actually dislocated out in this view, but that's what allows, that also has very similar type of cartilage in there, so it allows very smooth, the surfaces to move together very smoothly together. This is an example of our arthritic joint. On the left side, you can see the knee. There's actually almost looks like potholes there. It's where the cartilage has worn away down the bone. The bone is a little bit rough and it does not move as smoothly, so that can cause a grinding sensation sometimes. And you almost get the sensation of a quote, dry joint sometimes. As a result of that, sometimes your joints will try to secrete more of the lubricating fluid to compensate for that. And that's why sometimes a lot of people will get these swollen joints around the arthritic areas. So evaluation, what do we do? First of all, we want to get a good history of what the causes are, what things make it better, what things make it worse, anything you're taking that may help that. We want to do a physical exam. We want to find out how the knee is moving or the hip is moving around, the limitations. Diagnostic imaging is key, x-rays. Sometimes other imaging such as a CAT scan or an MRI can be helpful in this situation. And then finally, we'll do some type of a laboratory analysis, and that could include blood work, or it could include taking fluid out of the joint to send that off for analysis. The chief symptoms of arthritis is usually pain. It can be acutely occurring, or it can occur very gradual. The locations can be variable. Sometimes it's around a joint in the front, the back, the inside, the outside. And sometimes it's very poorly localized. Timing, is it worse in the morning when you get up? Is it worse in the evening at the end of the day? The quality of the pain, the sharp dull, what makes it better or worse? Is resting better, or does it get better as you start moving it? Effects of weight bearing and the effects on your range of motion. Any medications you take and how successful that is as far as helping. And then other associated symptoms, numbness, tingling. Sometimes that can be a sign of referred pain from another area. For instance, sometimes people will come in with hip pain, and we'll find out that the hip looks okay, but it's really referred pain from the back. So you really need to pay attention to those things as well. Stiffness, it's kind of like that rusty hinge. It just doesn't seem to get moving. You're kind of like the Tin Man and the Wizard of Oz at first when you get up. As you get moving, sometimes it does loosen up. Crepitance, I kind of look at that as the difference between driving down a nice smooth road versus a cobblestone road. It's that crunchiness, that bumpy feeling you get sometimes when you move that joint. Other symptoms include things like a limp, and a lot of times people don't even realize they're doing that. I have a number of people that come in with their spouses, and they'll say, "No, doc, I feel fine, I don't limp," and the spouse will look at them and say, "Of course you do, you're limping all the time, you just don't notice it." So sometimes it can be perceived, but sometimes it's not perceived. Swelling in the joint, that knee on the left side is very swollen compared to the normal one on the right. And that can be for a number of reasons, but it's usually as a result of some type of overproduction of that lubricating fluid. Deformity. We all know people who have kind of bow legs or kind of knock-kneed, and that can be a result of uneven wear of the joint. Usually if the inside of the knee would wear out, you tend to become more bow-legged. If the outside of the knee wears out first or faster, you can become more knock-kneed. And we've all seen people walking around that way as well. So that's something we take into account. Leg length difference. Sometimes if that cartilage wears away, that limb, in this case the leg, can actually be a little bit shorter. This is certainly an exaggeration here, but it can be sometimes several millimeters or sometimes as much as a centimeter difference, because sometimes once that cartilage wears away, the bone starts wearing away, and sometimes you take that nice round ball and it looks like a mushroom by the time you get to surgery, just because the bone actually gets ground up and it wears away. On exam, we'll look for the types of things we're talking about: swelling, range of motion, deformity. And then after a good exam, we'll go to diagnostic imaging. This is x-rays of a hip. The normal hip on the left, you can see a clear space between the ball and the socket. And I'm sorry for this thing cutting out every now and then. And on the right-hand side, you can see there is no space between the ball and the socket, and actually the bone looks a little denser, it's whiter there. That's the body's reaction to the stresses on the joint. It's called subchondral sclerosis. And if you look really closely, you can see these little kind of holes in there. It looks like little round circles. And those are what they call degenerative cysts. And those occur as a result of the inflammation that's occurring around the joint. In addition, you'll usually see bone spurs or osteophytes that form, and I kind of look at that as your body's way of trying to shore up the joint as part of the process of it wearing away. This is an example of a knee x-ray on the left-hand side. You can see the joint spaces on the inner and outer side. In this case, the outer side of the knee is on the left, the inner side's on the right. And then on that x-ray on the right, you can see that that joint has just totally worn away on the right side. There's no bone, there's no joint space left there. And that person would be bow-legged if you saw him walking around. Sometimes we'll use alternative or other imaging techniques. This is an example of an MRI. On the left side, we're looking at the knee from the side. The femur's on the upper part of that, and the tibia's on the lower part. There's an arrow pointing to the meniscus. It's probably tough to see from back there, but that meniscus should look like a dark triangle. And in this case, you can see in the middle of it looks white, and that's a sign of degeneration. On the right-hand side, that's an arthroscopic image of the inside of the joint, and you can see the white on the upper bones, the femur, kind of the lower left is the tibia surface, and the lower right is the torn meniscus there that showed up on that MRI scan. So that can sometimes be very helpful. And finally, we look at tests sometimes. A lot of times we'll take fluid out of the knee joint on that left side. That's a knee aspiration. We'll actually take a needle and put it in the joint, take some fluid out, and we can diagnose things like infection, gout, something called pseudo-gout. Gout is actually increased of uric acid crystals in the joint, and pseudo-gout is actually calcium crystals. Oftentimes, too, we'll see someone come in with a swollen joint, and it's because they may have had some bleeding in the joint. We see that actually a fair amount in people who are on blood thinners, like Coumadin or Xarelto or some of these other thinners, after sometimes a minor trauma. In addition, we'll do blood tests to look for signs of inflammatory types of arthritis. We'll check their white count in the blood, ESR, or erythrocyte sedimentation rate. That's what we call an inflammatory marker. When that's elevated, it's usually some type, an indication of some kind of inflammation in the joint, or a CRP or a C-reactive protein, also an inflammatory marker. And we can check for things like rheumatoid arthritis, Lyme disease, other things that can also cause significant arthritis. So as far as how to deal with this, so things to try first, and this is pretty well established. First of all, activity modification. If you're doing something, especially high-impact activities, you may want to think about modifying those activities to take stress off the joint. In addition, medications, over-the-counter NSAIDs like Advil or Aleve, Tylenol can be very helpful as well. Topical agents. There is some topical nonsteroidals, one called Voltaren cream on the market. It used to be a prescription, but now it's available over the counter. Other things, for the older folks out there, Bengay. I don't know if anyone remembers that. Flexol, Icy Hot seems to be a big one now, and one I don't have in there is CBD seems to be a real big one these days, with varying amounts of success with these. Ice or heat. Ice seems to be probably the most successful. Ice decreases inflammation, decreases swelling. Sometimes heat is helpful to kind of loosen up a joint and make it feel better. A lot of people will report to me anyway that heat makes the joint feel better. It doesn't necessarily help with things like swelling, but sometimes it does help with motion and that sort of thing. And a lot of times I'll tell people to use some heat on the knee first, or on a joint first to loosen it up, and then after an activity, ice it down. A light brace or a wrap, that can be very helpful, and I'll get to that a little bit later, but sometimes just providing some sort of external support can be very helpful in a symptomatic way. Weight loss. That's a big thing, and it goes to, again, decreasing the stress on the joint. Everyone's got these smart watches. They walk around, they're counting their steps during the course of the day, and routinely people say, yeah, I took my 10,000 steps today or whatever. And the reason I have this in here is I want to emphasize, even sometimes a modest amount of weight loss, say 10 pounds, if you take 1,000 steps a day, a 10-pound weight loss or change in weight equals 10,000 pounds different that joint sees a day. And there's actually some data out there that because of muscle forces around the joints, that is actually multiplied sometimes 2 to 3 or even 4 times, depending on what your activities are. So you can see that really even a modest amount of weight loss can make a big difference sometimes. Holistic supplements, that's really big. There's probably too many to count out there. The most common ones, glucosamine, chondroitin sulfate. These are some of the building blocks of cartilage. MSM, and I can't pronounce the name of that's after that. But that's actually, has anyone ever heard of DMSO? That was a big thing for treating joint pain probably about 15 years ago. And this is actually sort of a precursor of that. Omega-3 fatty acids improves blood flow, and a lot of people come in on turmeric, ginger. Those things tend to be more like natural anti-inflammatories. As far as medications, these are more prescription type meds. This is once you find your way to the doctor, usually prescription NSAIDs, aspirin, not quite as popular, but ibuprofen, naproxen. There's actually a whole list as long as your arm of different types of anti-inflammatories. They all work very similarly. to try to decrease the amount of inflammation around the joint. Tylenol, that's a good pain medicine. Varying degrees of success. It is not an anti-inflammatory, it's a pure pain medicine. DMARDs, or the disease-modifying anti-rheumatic drugs, those are for things like rheumatoid arthritis. They have changed the game when it comes to these inflammatory conditions. Before, for instance, rheumatoid arthritis can be very destructive to a joint, but with the introduction of these DMARDs, it's really had an incredibly positive effect on preserving joint function and actually limiting or eliminating the destruction of the joints. Prednisone or cortisone, very common. We'll do that, and actually, usually that's something that would be probably more prescribed by a rheumatologist for these types of things, but typically that is an anti-inflammatory as well. It calms down some of the irritation of the joint. In addition, you can add things like muscle relaxers. Oftentimes when someone does have arthritis, they'll get some muscle spasm, muscle tightness, and that can be helpful. For chronic pain, certain antidepressants can be very helpful. Narcotics, for pure pain relief, that's something that obviously is very controlled. It's not a good option for chronic pain, and you can, if you're prescribing for that, you can really head down a very bad pathway. Others, gabapentin and Lyrica, those are also medications that are used for more chronic pain and can be very helpful with mixed types of arthritis and nerve pain, and can be very helpful under those circumstances. Mobility aids. Once someone gets to the point where they're having trouble walking, canes, crutches, walker can be very helpful. And we try not to get to that point on the right where someone's in a wheelchair. We tend to use more canes and walkers. We want people to be as weight-bearing as they can comfortably be. Crutches tend to be a little more difficult to manage, especially in the elderly. And that's something that's probably more safe for more traumatic or acute injuries. As far as medical treatment, I put stars next to these, and I'll tell you the reason why is the American Academy of Orthopedic Surgery has looked at treatment options and has sort of come up with a guideline as far as which types of medications and which types of things to use. The more stars, the better, basically. So one of the things, surprisingly, is patient education. If you can educate someone about the causes of their arthritis and things that may help them, you find you get a much better response as far as how they deal, as far as how they can cope and work toward either alleviating or minimizing their pain. Prescription medications, that gets a 4-star rating, and we're talking about both Tylenol and the non-steroidal anti-inflammatories. That's been found to be very helpful for easing the pain of arthritis. Physical therapy also, and the way that works is by increasing the range of motion, the comfortable range of motion. Oftentimes you can significantly impact someone's pain. A lot of times with arthritis, as a joint gets stiffer, the limitation of motion becomes painful. So if someone's got a knee that moves from 0 to 90, 95 degrees is going to be very painful. So if you can increase that motion to say 100 or 110 degrees, now that 95 degrees isn't painful anymore. So it also restores more muscle balance and restores more normal mechanics around the joint. We talked briefly about ambulatory aids. Braces can be very helpful by providing some support around, and I'll again give an example of that down the road, and injections, which we'll talk about too. So physical therapy improves motion, flexibility, endurance. The braces, that brace on the left is what they call an unloader brace, and that's a brace that can be used if someone has arthritis in a specific area of the joint. Say, if it's on the inner side or medial side of the joint, that brace is designed to concentrate the forces on the outside of the joint and actually open up that inside of the joint. So it can alleviate pain by just decreasing the stress on the arthritic area. The trouble with that is you have to wear them tight for them to be effective. They are pretty bulky, but they're good for doing certain things if someone's playing golf and they want to be able to walk the course or play golf comfortably or something like that. It's good for specific tasks to do. The one on the right there is just what we call a knee sleeve brace. These come as a sleeve where you pull it on, or they can wrap on. I usually prefer the wrap-on type because you can adjust those to snug them up or loosen them up based on what your activity level is. Knee injections, and there's several of them out there. Cortisone is probably the most popular. In that case, we're putting an anti-inflammatory directly into the joint. So cortisone injection, what is it? It's a corticosteroid, and usually mixed with some type of a short-acting anesthetic. It's injected directly into the joint, as it says, usually covered by insurance, and it's very effective. This gets pretty high marks, 3 out of 4 stars for the AAOS as far as the treatment. It tends to be a little shorter acting than some of the other treatment options. And some people sometimes can get some reaction to it, either a flush feeling or some localized pain afterwards. And it's best for painful or inflamed joints, especially more acute or a flare-up of pain. Hyaluronic acid, the so-called rooster shots. This is basically a lubricant. We're trying to introduce a synthetic form of your own natural lubricants. The feeling is that by injecting that into the joint will move more smoothly and over time decreases the inflammation. That sometimes can take as much as a month to take effect. The results are somewhat variable. Initial results in that actually seem to be very positive, with longevity of the injection lasting sometimes 6 months or longer. Some of the more recent data coming out from some of the studies call that a little bit into question. So there's still some controversy, I guess is probably the best way to put it, as far as who is the best candidate for this type of thing. It's usually covered by insurance, but it's variable. Some insurances cover it, some don't. The benefits is it sometimes can give some fairly long-lasting results. And there are some people that I've given this to that do very well with it. And I think there probably are, and a lot of the studies seem to indicate there's probably at least a subset of people out there that it can be very effective for, though it's not always effective for everyone with arthritis, and it probably works best in mild to moderate arthritis as opposed to more severe. And then regenerative treatments. This is something a little bit newer on the horizon. In this case, we're injecting things into the joint that will hopefully help either mend it or heal it. This includes something called PRP, or platelet-rich plasma, stem cell therapy, and something called prolotherapy, which you may or may not have heard commercials on the radio about. So PRP, what's that? That's platelet-rich plasma. In that case, what you do is you take some, basically you draw blood, a certain amount, and then spin it down in a centrifuge to concentrate. Is that still going? There we go. It concentrates the platelets, and these platelets seem to have some type of either anti-inflammatory effect or mediating effect of the inflammation in the joint. Insurance generally does not cover it, and it can be expensive, sometimes several $1,000s for treatments. As far as the benefits, it can be probably helpful in a certain subset of people, and there's been some studies that show it can be as effective or more than some of the hyaluronic acid injections. It is mainly used for osteoarthritis, but theoretically can also be helpful for inflammatory types of arthritis, since it does introduce an anti-inflammatory into the joint. Stem cells, that is probably a little more controversial. In that case, what you do is you harvest stem cells either from bone marrow or, in sometimes fat. You almost have to do a mini liposuction, which some people may be up for. But and in that case, you have to process that specimen to try to concentrate the stem cells that are in there. And stem cells are cells that basically can turn into a number of different types of cell lines. The hope is that they would turn into cartilage cells and rebuild the cartilage. It's usually not covered by insurance. It is invasive, and it's very expensive for treatments. It's still kind of being sought out as far as the best approach to that. I think it's early in its treatment process, and I think there'll be more to that to come over the coming years. Prolotherapy, this is something where you actually inject an irritant into the joint, and the idea behind that is it's supposed to help the body to generate its own healing response. It's usually some type of a sugar solution, though can be others, and it usually entails multiple injections. In this case, they cited 15 to 20, and it is fairly expensive over time as well. So I'd also like to note that none of these things actually do rebuild the cartilage in your knee. What it tends to be is more of an anti-inflammatory effect. There's never been any studies to show that this actually makes your cartilage in your knee or your hip, for that matter, rebuild and come back to normal. Other treatments that are out there, massage, which we all like, it feels great, but as soon as you stop, it probably isn't that helpful. Manual therapy, that's manipulation therapy, and that same with that. These all get, you see I have the 2 stars up there, these all get kind of a 2-star from the American Academy of Orthopedic Surgery. Laser treatments is another one that there are some data out there that shows that it could be helpful, just not enough out there that they can make a recommendation. Acupuncture, it's used for a lot of different things, including arthritis. I think probably as far as conclusion, that's still trying to get figured out. TENS unit, that's electrical stimulation, same thing. While it's on there, it might be helpful, but it doesn't create any real long-lasting effect. It works potentially while you're wearing it and that unit's turned on, but that's probably about it. Shockwave therapy, there's not really a whole lot of data. I think that comes from some shockwaves used in other areas. Dry needling is another, and not that doesn't work. I think that, again, there's probably a certain population of people that this might work on. That's probably better for things like tendinitis and that sort of thing. Just need more data, more studies to come up with whether that works. Denervation therapy, you may have heard of something called coblation or something advertised on TV. And in that case, what you do is you try to deaden the nerves around the joint. So in that case, it doesn't affect the arthritis at all. You just don't feel it. It's trying to basically put those nerves to sleep so you don't have as much pain. So anyway, in conclusion, rules for chronic joint pains. It's stay as active as you comfortably can. The more you can move that joint, usually the better it's going to feel. Most studies seem to indicate people who stay active tend to have less pain and better function compared to people who don't. Substitute things you can do for things you can't. If you can't bungee jump, try something else. It's the old doc, it hurts when I do this. Well, don't do that. And that comes down to that substitution. Substitute something you can do. Heat it up, turn up the heat. That can help as far as comfort and loosening up a joint. Icing it down or cooling it down after can be helpful. Smoking, that can be a risk factor for arthritis as well. It decreases blood flow to the joints and can limit the amount of healing potential that can get to those joints. And continuation, wrap it up. Try a brace or a light wrap. That can give some support. And sometimes just that feeling that contact around the joint can be helpful. Try to have a modest amount of weight loss for those people who are overweight. Eating healthy. Before you do an activity, stretch. Make sure you're loose before you start. If the pain persists, you may want to consider teaming up with a physical therapist. Mind over matter, that's the mental side of this is just as important as the physical side in a lot of cases. So when to seek medical attention, if your joint pain is very severe, unexplained, it's lasting more than it should, 3 to 7 days, that's, depends on what the problem is, especially if it's an injury, you may want to be seen for that. If the joint's hot, red, or swollen, that can be inflammation, but it can also be infection, and that's not something you want to have lingering around. Associated fever or chills, that also could be an indication of infection. And if you're getting no relief from the things you're trying, the medications, icing, that sort of thing. If you've recently injured the joint, especially with some kind of a sharp blow, that can be a sign of possible damage to the joint that you may want to get checked out. And that's it. Thank you so much.